Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and I'm so glad you're joining us today. Joint pain from arthritis or injury can make everyday activities difficult, and many people wonder whether joint replacement might be the right option for them. At the same time, there are a lot of myths and misconceptions about what surgery involves, who it's for, and what the recovery looks like. Today, we're joined by Dr. Jeffrey Matheny, an orthopedic surgeon at MedStar St. Mary's Hospital and part of the MedStar Orthopedic Institute. Dr. Matheny will help us clear up some of the most common myths about hip and knee replacement, explain how those procedures have evolved, and discuss what patients can realistically expect before and after surgery. Whether you're experiencing joint pain yourself or simply want to learn more, we're so glad you're here. If you'd like to learn more, stick around, share this broadcast with your friends and family, and ask your questions in the comments below. We'll answer as many as we can during our discussion. Thank you so much for joining us today, Dr. Matheny, and for sharing your expertise with our viewers. Before we begin, can you tell our viewers a little bit about yourself?
Sure. First off, just thank you for this opportunity. I love total knee replacement. It's one of the favorite surgeries that I do, and it's been a passion of mine over 25 years. So I'm glad I had this opportunity to talk about it and share some of the insights. But yeah, I'm from Pittsburgh, Pennsylvania. Grew up there. I've spent the majority of my career there, 25 years. I've been doing this, and recently moved to Southern Maryland. My kids are out of the house now, so I was looking for some new challenges, some new, things to explore. My wife and I love this area. We love the outdoors, so here I am. Yeah,
Thank
that's
you so
about
much.
it.
I guess
Yeah.
first thing, are you a Steelers fan?
Unfortunately, yes. Yeah, I'm a big Pittsburgh fan. More of a Penguin fan, but yeah, I love the Steelers as well.
We won't hold it against you.
Yeah.
Let's get started on some questions. At a basic level, can you explain the anatomy of the joint and what parts are replaced during a joint replacement surgery?
Sure. Yeah. One of the myths is that during a knee replacement that we have to remove your entire knee. And so, yeah, it's good to talk about the anatomy first. And so I do have a model here, which basically shows what the knee looks like. And it is a hinge type joint, but it does have side ligaments, and it has this central quadriceps tendon and patellar tendon. And then the cartilage is the white surface that covers the end of the bone. And then there's the meniscus, which sits between the bones. So for a knee replacement, what we're doing basically is not removing your whole knee. We're leaving all of your ligaments on the side. You get to keep all your quadriceps and your patellar tendons, but we basically resurface the knee. And so this is what it looks like. It's like a metal cap that goes on the end. So we're basically removing the cartilage on the end of the knee, and then a piece of hard plastic between, and so it works like a hinge joint.
Wow.
But once again, you keep the majority of your own tendons and ligaments, and so it's really more like a resurfacing procedure.
Wow. That's impressive. Can you explain the different types of joint replacement surgery patients might hear about, such as partial versus total and
Yeah,
anterior
sure.
versus traditional?
Well, yeah, the most common is the total knee replacement. When they say total, that means both both compartments. This is the inside and outside compartments. So this is what a total knee replacement looks like. There are partial knee replacements where you can just replace
Can you
half
hold
the
it up a
knee.
little bit higher?
Oh, sorry.
There we
Yeah,
go.
you can
Yeah,
just replace
perfect.
half the knee. So if
Okay.
most of your arthritis is in one side of your knee, then you can just have a more limited procedure where they're just replacing uh, one half of the knee
Okay.
versus the whole knee. And there are some advantages to that. It's a little quicker recovery, and you get to keep even more of your knee, obviously. So some patients are candidates for a partial knee, but once again, that's a discussion with your doctor. There are some limitations on who qualifies for that.
Okay. Can you talk about anterior versus traditional hip replacement?
Yeah, That's a sort of a different category
Okay.
as far as hip replacements. But yeah, that is a very common question these days on hip replacements, anterior versus posterior approach. And the traditional approaches have both mainly been posterior, and the newer approaches are anterior. And so uh, basically, the literature is showing very similar outcomes between both of those surgeries. Maybe a little bit quicker recovery with the anterior approach initially, but at the as time goes on, both those approaches are about equal.
Okay.
Yeah.
And then it also mentions reverse versus traditional shoulder replacement and then robotic versus outpatient options.
Right. So yeah, for shoulder replacement, that's there's two options there. The standard total shoulder replacement is just replacing the ball and the socket. And for reverse, which is what we use on somebody that doesn't have a very good rotator cuff, which forms the roof of the shoulder, we actually replace we just switch them. So the ball goes on the socket and the cup goes on the humerus, and it works more like this. And it
Oh,
takes the rotator cuff out of the equation. So you're using more of your bigger muscles in your
okay.
shoulder to function. So, yeah.
That's a lot of different options. So with so many options available, how is the right procedure determined for each patient?
Yeah, I mean it's an individual basis. It's sitting down with your doctor, looking at what the options are as far as all your studies and where you are. But yeah, it's basically just sitting down and going over that with your doctor.
Okay, one myth patients sometimes hear is that they won't be as active as they want to be after joint replacement.
Yes, very, very common concern for people. And yeah, like I said, it's a very good surgery as far as making people more active.
Mhm.
So there's really very few limitations, believe it or not, after you've had a knee replacement, other than I don't encourage patients to run or do high impact activities after having a knee replacement, but you can do most things after a knee replacement, including pickleball, including tennis. Some people ski, and if you're a good skier, that you could do that. I wouldn't pick up skiing after you've had a knee replacement, but yeah, you can be very active. In fact, that's why we do the surgery is we want to restore people's activity level to a higher level. So yeah, that's not a reason, certainly not to have the knee replacement.
Yeah, that makes
Yeah.
sense. Another myth is that someone could be either too young or too old for a joint replacement. Why might people believe that? And how do you determine whether someone is a good candidate for a joint replacement?
Yeah, that myth has been out there, and initially when joint replacement first started being done, the components weren't quite as good, and so I think there was a shorter lifespan, and so we were telling patients, even when I first started, that 15 to 20 years you're going to have it revised. But certainly what I've seen as my career has progressed is better components, especially the piece of plastic in between is much harder. And so the lifespan of the knee replacements lasting much longer. So I mean, you can expect 25 to 30 years, I think now. I've been doing it for 25 years, and I've been shocked on how few patients I've done surgery on have come back for revision. So yeah, it's really not something that should limit you. It's really more about quality of life. You want to, if you're in your 50s and you're miserable and you can't do the things you want to do, it makes sense to
Mhm.
have improve your quality of life for the years that you have. And like I said, 30 years, you're in your 80s. It's like I said, you're not as active at that point. You're not likely going to need it revised. So I think we
Mhm.
are sort of moving down the time that someone would be eligible for a knee replacement, just because, like I said, the components have gotten so much better.
Oh, that's awesome.
Yeah.
Very cool. Um, my next question, what are some common signs or symptoms that might indicate someone should start thinking about joint replacement?
Yeah. So yeah, it's really a discussion with your surgeon about this. But there's really no hard sign. It's really more a combination of, the quality of your life and how much the symptoms are interfering with what you want to do, combined with obviously the assessment of the x-rays. So it's really a combination of, the x-rays showing bad arthritis, bone on bone almost, and the patient's quality of life being affected to the point where, in my case, I wait for them to come to me and tell me that they're ready to have the surgery. So I don't ever, force somebody to have it based on an X-ray. It's a combination of their symptoms and how much it's interfering with what they want to do with their life, and how active they want to be, and the X-rays.
Okay. When a patient comes to see you with joint pain, what does the diagnosis process usually look like?
It's obviously we look at the history and how long they've been having symptoms, and what brought on the symptoms. But yeah, it's a whole process we go through, including the physical exam, where they're sore, where they're tender. Then we put it together with the X-rays, and it's just a common decision on our part on what's the most common things in certain situations. But usually with arthritis, it is a slow and gradual worsening over time. And obviously, when they come in the first time to see us, we don't sign people up right away for joint replacements. We spend a lot of time non-operative management, starting with medications, activity modification, weight loss if we need to, sometimes physical therapy. And then there's multiple injectable treatments we'll try first. And it's only after we've exhausted all of those non-operative options, and like I said, they just are to the point where nothing's really working, and they get up in the morning and they just can't imagine what their day is going to look like. So
Mhm.
yeah.
Oh, that's good to hear that we're not just jumping straight into joint replacement. That might
No,
first.
definitely not. Yeah.
So I'm just going to pause and reintroduce our broadcast. If you're just now joining us, my name is Amy Cameron, and I'm here with Dr. Jeffrey Matheny, orthopedic surgeon at MedStar St. Mary's Hospital and part of the MedStar Orthopedic Institute. Today, we're discussing common myths and facts about joint replacement surgery. So if you have questions, leave them in the comments, and we'll get to as many as we can during our discussion, which I think we actually have some from the audience. Karen asks, I had a hip and knee replacement. I expected my right leg to feel normal. I guess in 2022, she's saying, I have a lot of scratchiness, stiffness, and although the stabbing feeling is gone, it's not like a normal knee.
Yeah, that's actually a very good question, because that is a very common complaint. And one thing, I definitely address that with my patients before the surgery. They really have to have realistic expectations. It's not going to restore that knee to when you were in your 20s. It definitely improves symptoms, however, daily living and pain, and like I said, activity level. But yeah, it's not perfect. It still can be stiff at times. Coming down and going upstairs can still be painful, very common complaint after knee replacement. Some swelling also is common. But like I said, overall, it restores activity in a lot of people, and very, very high patient satisfaction scores across the board for knee and hip replacement. Some of the highest patient satisfaction scores of any surgery that's done, not just orthopedics. So overall, I think everyone's going to have that person out there who's had a bad result, and it might scare them from pursuing it. But I can tell you, after doing this for years, that the good stories far outweigh the horror stories. So
That's great. We have another question from Jim. He is asking about the GAE vascular treatment, which is a type of injection. And you mentioned injections a little bit. So he's asking, what is the role of injectables in managing joint pain?
well, right now, there's only two injectable treatments that are approved, or that are covered by insurance, and that's cortisone, very common.
Hmm.
And we do use that as a first line agent, probably in most people with arthritis, and it's basically an anti-inflammatory, um, relatively safe. We don't repeat that more than 4 times a year, but it's rare that we even use it that often.
Oh, wow.
But that is a very effective treatment initially, and then seems to decrease over time. And so then we switch to what's called viscosupplementation, which is fancy. It's basically hyaluronic acid, and it's basically a component of cartilage that we're injecting into the knee, and also works in a chemical way by decreasing inflammation about the knee, just a
Oh,
different pathway, different mechanism than cortisone.
okay.
And unfortunately, the results with that can be somewhat mixed. We still try it, even though um, there are definitely in my hands experiences where it's been very effective, but there are also stores where it doesn't really help that much.
Mhm.
So,
Okay.
but we at this point we're still using it. And then there are other treatments that are usually not covered by insurance. PRP injections, where they take your blood and they spin down the plasma
Mhm.
cells. Definitely is some literature showing that that can be effective in decreasing inflammation. Can be somewhat expensive,
Mhm.
somewhere around $500 out of pocket. But some research showing that can be effective. And then stem cells, that one's more expensive. And unfortunately, the literature is not showing that to be very effective, unfortunately, for knee arthritis. But there are definitely some novel treatments coming down the road. Been reading research about injectable treatments, which are regrowing some cartilage in the knee in animal studies. Human studies have not started with that yet, but I think we're going to see some very interesting injectable treatments for arthritis down the road.
Oh, wow. That's very interesting. Karen asked another question. I have bone on bone in my left hip. The hip doesn't bother her, but she has knee pain. Do I get left hip replaced anyway because the knee gets replaced after the hip? And why?
Well, yeah, it's can be difficult sometimes because the pain from a hip can often present as knee pain. So
Oh,
that would have to be an exam by her physician. But yeah, I surprisingly see a fair amount of patients that come in for evaluation of their knee, and it's bad hip arthritis.
wow, that's very interesting.
Yeah, there's a certain pattern of pain that we see with hip arthritis that makes that we pick up right away, knowing that it's not
Okay.
from their knee; it's coming from their hip.
Okay, wow.
Yeah.
I would not have guessed that. Let's get back into some of our other questions. We often hear from people who say they waited years for a joint replacement and later wish they had done it sooner. Is that something you hear often?
Yes, we do, but yeah, once again, it's one of those things. I never talk somebody into a knee replacement. They really do have to be ready mentally
Mhm.
to have it done, and patients are. By the time they sort of know when it's time, and they show up requesting it.
Mhm.
So yeah, I wouldn't say I do think that a lot of people do say that after they've had their knee replaced that they wish they would have done it sooner. But once again, it's still not something that we would say, yeah, you better get this done. It's that the patient has to be ready to have it done.
Okay. And after a joint replacement is recommended, how long should a patient wait until they actually have surgery?
After it's recommended,
Yeah, so if you decided a patient was ready for a replacement, is there a wait time between that and the actual procedure?
there usually is a wait time. It can vary depending on how busy your surgeon is, but typically it's at least 4 week process, just because we do have to get some clearance from the medical doctors first, which requires some time. But
Okay.
yeah, usually the leeway is about 4 weeks. But once again, if you have a very busy surgeon, it could be longer than that.
Okay. And You discussed this a little bit, but if we could revisit, one myth is that a joint replacement only lasts about 10 years. Can you discuss again the typical lifespan of modern joint replacements or joint implants?
Yeah, like I said, it's the design, particularly of the plastic parts of the joint, have improved significantly. So the wear from that and the loosening that can be caused by that wearing out has really decreased. Certainly in the time I've been doing this, and so yeah, where I said before, 10, 15 years is really not what we see. It's certainly longer than 20, and often even much longer than that.
Okay.
And yeah, like I said, I would say at least 25 to 30 years would be to be expected.
And historically, how have joint replacement procedures evolved?
Yeah, it's like we've talked a little bit before. I think the robotics thing is probably what's also changed in the past 5 years, or maybe even longer than that. And so basically, we're using robots in surgery now to help us make those resurfacing cuts a little bit more accurate. So um, that's been very helpful, particularly with more complicated cases. I don't think a lot of surgeons have incorporated it just yet into their daily routine and workflow, just because it does increase operative time right now. So, but it's clearly going to be part of what we do in the future. But it's in the process now of becoming more streamlined so that we can use it a little bit more efficiently and prolong the patient's operative time.
Hmm.
Um, Studies are showing also that it's not improving outcomes as much as we would like. So I think there's some tweaking of what we're doing with that, but I clearly it's going to be a part of what we're using in the future.
Okay. Very cool. What steps can patients take before and after surgery to help ensure the best outcome?
Yeah, we in some cases start them on some exercises just to improve their muscle function prior to surgery. I think that can help certain patients
Oh,
post-operatively if they go in with a little bit stronger leg, a little bit better range of motion. And then post-operatively, yeah, we just start very active exercises right away. Your weight bearing as tolerated. A lot of times, patients are going home the same day as their surgery, which has changed. That's been a big change over the past several years.
okay.
And therapy starts at home. And in our case, we do use a machine at home as well to help regain that range of motion. But patients should expect that it's going to hurt a little bit when they start, particularly moving it and getting that range of motion. So they do have to expect a little bit of discomfort. And the patients that have the best outcomes with knee replacement surgery, particularly, are the ones that really are pushing through some of that pain in physical therapy. But yeah, unfortunately, there's no way to do a painless knee replacement,
Right.
even though some people uh, do advertise that. That's not typically the case, and it can be a far range of symptoms as far as after knee replacement. Some have very bad pain, some hardly have any pain at all. It's more a factor of the patient than what we do.
Mm.
But in general, it's not as bad as it used to be. That's why, like I said, we're sending folks home same day, full weight bearing,
Wow.
beginning range of motion right away, walking, pretty comfortably by 2 to 4 weeks, returning to work in a lot of cases, 4 to 6 weeks, returning to
Okay.
activities, 4 to 6 weeks. So not the extended outcomes we used to see where they were in the hospital for 2 weeks after their surgery. So
Wow.
things have really moved along.
Yeah, that's quite the change. That was going to be
Yeah.
my next question about how quickly can you return to work? Some people think 3 to 4 months, but you said 4 to 6 weeks, right?
Well, I mean, it obviously depends on what that
Okay.
person does. Yeah, I mean,
Okay.
if it's a manual labor position, that's obviously going to be a longer recovery as far as going back full duty. But I mean, if it's a desk job, sedentary work, yes, you can get back to that very quickly.
Okay.
No driving if it's a right side for 4 to 6 weeks. If it's the left side, 2 to 4 weeks. So,
Okay.
um, yeah, not as long as some people think, and that's definitely one of the myths that is out there, that it takes a very long time to recover.
Hmm.
And it's probably, like I said, on the earlier range of that.
Okay, that's good to know.
Yeah.
What else should patients expect during the recovery process?
Um, yeah, I mean, like I said, it's not pain free. It's going to be a little uncomfortable, especially at first. But like I said, very high patient satisfaction. Um, Not as many limitations as people think. Post op, you can kneel on a knee replacement.
Oh, okay.
Obviously, we don't want people down doing floors, for
Yeah.
prolonged periods of time on a knee, but you can certainly kneel at church or kneel on the knee to do some light work. That's a very common question we get as well. And like I said, short of running on these, you can do most activities safely.
Okay. And what is the long-term outlook for patients who undergo joint replacement surgery?
Very positive. Very, like I said, very high patient satisfaction, improved quality of life, mainly from a pain perspective. Unfortunately, range of motion ends up being about the same as they start with, and that's just a matter of that fact that we aren't replacing the whole knee, just the resurfacing it. So you still have your old ligaments in there, and so there's some restrictions in range of motion still after we do this. But in general, it reduces pain, and so what patients can expect long term is significant improvement in their level of pain with their activities.
Yeah, I'm sure that definitely outweighs the restrictions.
Yeah.
What are there any lifestyle changes patients should plan for after surgery?
And like I said before, unless they're a runner, and unfortunately we have a few people that still run on these, and stories are that they can do it, but it does put a lot of stress on the knee.
Hmm.
So I currently don't think that's a good idea. I think that would increase your chances of needing that revised earlier. But like I said, there's very few restrictions. We do recommend still taking some antibiotics if they have an invasive procedure, dental work, colonoscopy, uh, but that's changing as well. And I think that that recommendation may change soon as far as the need to continue to do that for invasive procedures after knee replacement.
What was the reasoning for that?
Uh, that when you have a procedure that the bacteria can get into the bloodstream and seed the knee with an infection.
Oh,
So
okay.
we give patients antibiotics to protect the knee
Yeah.
from seeding from the procedure being done somewhere else. But unfortunately, the literature isn't very strong with this. So, like I said, I would expect changes in those recommendations coming down the pike.
Oh, okay. We had one more question come in from the audience. Is there a BMI limit? And what is the relationship between BMI and joint replacement?
So, yeah, that's also a very common scenario these days. Currently, well, at least over the past several years, we had been using a body mass index of 40. The literature seems to show, a curve as far as complication rates
Uh-huh.
during and after surgery, sort of peaking, and at that cutoff of 40, they tend to go up. But that's also changing, and we're starting to see that it's just not the body mass index that's important, but the overall health of that
Mhm.
patient. So in some patients that don't have a lot of other comorbidities or heart or lung disease, or not a lot of comorbidities like diabetes or
Mhm.
kidney disease is a big one. We don't we If they have any like significant health issues, then the body mass index does become a very important factor. And we
Okay.
do encourage patients to start to get that down to decrease their risks of complications during and after their surgery. But like I said, we're starting to see that the complications, if you don't have a lot of comorbidities, are pretty reasonable. So I think most surgeons are starting to extend that limit up a little bit.
Okay. That makes sense. We had one come in from Joanne. I had a knee replacement in late 2018, and the knee has gradually moved toward my right knee, making me increasingly knee knock or knock kneed. Sorry. I recently got a custom brace and I'm currently in PT. It is very painful, stiff, making all movement very difficult. It seems surgery to move it back into place is the option. What are your thoughts?
Yeah, I mean, without actually evaluating that patient, that's a hard thing for me to give an opinion about. But yeah, if somebody's drifting into a deformity, unfortunately, that means that the knee replacement is likely not seated into the bone like we would want it to, or that the bone is somehow deficient and collapsing somewhat and
Okay.
letting the knee tilt. But like I said, that's an uncommon scenario. But yeah, if it gets to the point where that does shift to a position where the knee's not functioning well, then sometimes that will require a revision
Okay.
surgery. But once again, like I said, that's not very common scenario,
Okay.
fortunately.
Okay. And Karen asks, is there a procedure for knees involving cement injecting? She said she knows someone getting this versus a knee replacement. Or is it part of a knee replacement? She's asking.
Yeah, I mean, there's no procedure where you would inject cement into a
Okay.
knee, but we do use cement to between the component and the bone.
Okay.
But once again, that's changing. And in somebody who's a little bit younger and has good bone, we're actually shifting away from cement and we're press fitting the components into the bone and avoiding using the cement. And so
Okay.
that's showing a lot of promise in research. It started with the hips. We showed that we stopped using cement for hip replacements and noted really good results. And so we're
Oh,
trying to use it less in knees and see if we can get the same improvement in results for the knee.
okay.
Yeah.
And she also asked, what is Jiffy knee? I've never heard of this.
I don't know what that means, actually. Sorry.
Kanika asked, I had knee replacement 3 to 4 years ago. I still experience pain, especially due to barometric pressure up and down. Weight loss, she's a senior and prefers not to take pain meds. Is there any good option? My knees give me problems. Are there any new surgeries? I guess is what she's asking.
So she already had a knee replacement.
Yeah, it looks like 3 to 4 years ago.
Okay, yeah. Once again, it's really hard for me to give someone advice without seeing them, examining them, looking at their X-rays. But yeah, unfortunately, a subset of patients don't do well from the surgery, and a little bit more patients with knee replacement don't do well versus hips. I think hips have a little bit higher patient satisfaction, and there are a subset of knee replacement patients that honestly we're trying to figure out why they don't do as well.
Mhm.
It's being studied. Why there are, like I said, a subset of patients that don't respond well. But like I said, it's few. It's not the
Okay.
majority, but they're definitely out there, and it's being researched. And I think we'll find out that yeah, it might be more of a biological thing, patients' genetics or somewhere along those lines that are reasons why some knees don't do as well as others.
I guess she's also asking, are the new surgeries better than they were 3 to 4 years ago? Or depending on the joints, are they less invasive and more substantial? I guess, are
I
there
don't
any
think,
changes?
yeah, I don't think you're going to see a lot of new changes in the past 3 to 4 years, other than, like I said, the robotic robotic use has increased,
Mhm. Okay.
and there's definitely advantages, I think, more for revision surgery with robotics than
Oh, okay.
primary or first. So in that case, yeah, her surgeon, if she goes back for revision, might use robotics. That might be the difference. But as far as the components, not a lot of changes. Yeah.
Okay. Okay. Great. Thank you. And Barbara asked, and I think you mentioned this, do any muscles or tendons get cut in the knee replacement?
So we do have to um, more split the tendons, so we don't detach the tendons from the bone, which is nice. Like I said, it's not as invasive as some people
Mhm.
think. But obviously, we do have to cut through some muscles and tendons to get into the knee, but we're splitting
Okay.
them versus detaching them. And so that's why we can move the knee so quickly after the surgery
Okay.
because we're not detaching something and reattaching it. So,
Hmm. Okay.
yeah.
That makes sense. Nan asked, how soon are you comfortable having a patient use a pool?
That I wait 8 weeks
Okay.
for the incision to completely mature, but that you'll see a lot of variability with surgeons on that. So you may have a surgeon who would let somebody do that earlier. Um, you can shower though pretty quickly. You can get it wet relatively quickly after the surgery. Within 2 to 3 days, the incision can actually get wet. We just don't recommend soaking it in a hot
Mhm.
tub or bath for a more prolonged period of time because of the risk of infection.
Okay, that makes sense.
Yeah.
She also asked, are there any concerns about a patient with osteoporosis being on, and I might not be able to pronounce this, alendronate when surgery happens?
No, not really. Obviously, bone quality plays a role in what we do as far as what we were talking about before, using a press fit versus cement. But the only thing it changes for us is we're just more careful when we're doing the surgery, as far as if someone has very thin bones with our retractors and how we perform the surgery.
Okay. And I think that's all the questions we have for right now. But before we wrap up, Dr. Matheny, what is one key takeaway you want people to remember about joint replacement surgery?
I think, like I mentioned before, it's not something that we jump into right away. So don't be concerned about showing up here and being signed up for a knee replacement. We spend a lot of effort in getting people better without surgery. But the key takeaway is, like I said, highest patient satisfaction scores across the board of any surgery. So it's a very, very good surgery for relieving pain and increasing activity and quality of life.
Okay, that's great. And that brings us to the end of today's discussion. I'd like to thank Dr. Jeffrey Matheny for taking the time to share his expertise, and thank you to everyone who joined us and submitted their questions. Understanding the facts about joint replacement and separating myths from reality can help patients feel more confident about exploring their treatment options. If you'd like to learn more about joint replacement or connect with a specialist, please visit the link in the comment section. Thank you so much for joining us today and have a great afternoon.